Our first speaker is Dr. Humayun Bashir. He'll be delivering his talk, very interesting, on a very interesting topic, that's molecular bone imaging and the risk of fracture assessments. And he is working at the moment at the East Kent University Hospital NHS Foundation, and he's an honorary consultant at Shoghat Khanum Cancer Research Hospital. He is a renowned nuclear medicine physician having more than 23 years experience, fellow of College of Physicians and Surgeons Pakistan, Royal College of Physicians of London, and Edinburgh, European Board, Edinburgh, as well as European Board of Nuclear Medicine. So Dr. Humayun Bashir, it's over to you now for the...
Hello, Assalamu alaikum. Thank you very much, Dr. Ambreen, for the introduction. I hope you can all hear me. Well, today I'll be talking about molecular imaging, molecular bone imaging for fracture risk assessment. To give you a bit of the background, now this discussion about bone metastasis, this goes way back. Dr. Stephen Paget recognized in 1889 that breast cancer had a predilection for metastasizing to the bone. This is one of the first papers published in Lancet back then. And then this theory of seed and soil was introduced. It was revisited in this paper published around 2004. The idea is that emboli of the tumor and the fibrotic stuff around the tumors that actually leaves the primary site of the tumor and travels across the motorways of the body to the vessels into systemic circulation and then seeds into bones. So that's the idea behind this, how the bone metastasis develop. Of course, tumors themselves are very vascular structures, and there's a whole predilection for having this capacity to pick the emboli and then sort of carry them around the body. So when these emboli of the tumor, they go and settle into the bone, there's a receptive environment there. There are two mechanisms in bones, osteoclastic activity and osteoblastic activity, and there's a very, conducive molecular environment there, which results in these mechanism, and the tumor cells become part of that whole, what you call microscopic or molecular process, while there's formation of new bone through the osteoblastic pathway, and at the same time there's osteoclastic activity going on. Now the biochemical markers, they're different for both osteoclastic and osteoblastic bone turnover, so the biochemical markers of bone turnover are released during this bone remodeling, osteoclastic as well as osteoblastic activity, and that develops into the different types of metastasis. Now these mechanisms at play provide the therapeutic opportunities, interventions into osteoclastic or the osteoblastic activity, provide the therapeutic opportunity for us to strengthen the bone, while the metastases are there to actually weaken, and as a sequence of the whole process of the tumor spread. Now with this background, these are two papers, one published in 2008 and the other published in 2018, 10 years apart, editorials by Dr. Alavi with some co-authors. And with the advent of FDG, like since early 70s, MDP is the tracer of bone imaging, better than any other imaging, very sensitive and able to identify the spectrum of disease in the bones. With FDG, this whole debate started that FDG is better than the bone tracer. So as a response to that, Dr. Alavi and his team wrote these two editorials trying to emphasize that it's not fair to compare an MDT tracer with FDG, because FDG is talking about metastasis in the marrow where the actual metastasis is, while the MDP is picking the secondary reaction to the metastatic lesion inside the bone. So we basically emphasize that we strongly advise that the concept of bone marrow instead of bone metastasis should be highlighted once you have FDG and more specific tracers in your hand. Now, going back again in history, this paper from 1917, the prognostic and therapeutic significance of skeletal metastasis in carcinoma of the breast. Now, Isaac Levine, in this paper, they actually identified that the mechanism of the development of growth of skeletal metastasis, and they sort of placed that at that time the modality, the best modality of that time was the X-rays, and they emphasize the need of X-rays in breast cancer patients, sort of to look for bone metastasis. So this, whole doing this workup for skeletal metastasis started around early 19th century, 20th century. This is a review published from 2020, which talks about the state-of-the-art imaging for diagnosis of the metastatic bone disease. And in this table, you can see, yes, it talks about the X-ray, CT, SPECT, CT, MR, PET-CT, and PET-MR, and every modality looks at different aspects. X-rays and CT look at the morphology, metabolism through radio tracers, marrow involvement, same radio tracers, while MRI is looking at the marrow, and the metabolism is looked at by, again, the radio tracers through hybrid imaging. Same paper, they have looked at various malignancies. You can see prostate, lung, bowel, bladder, and then breast, bowel, and lung in females, and the GU malignancies. And you can see that the marrow involvement is in all these metastases coming from all these different malignancies. While there can be some involvement of the bone, as we can see in the prostate gland, so the lesions are mixed, more mixed. Breast has also got mixed, but marrow is the consistent site of what we call bone metastasis. Now, with this background, there's a need to look for fracture risk assessment. Now, whenever in an oncology setting, it's a nightmare to know that the patient disease has spread to bones. Now, with that, while all the options to treat, systemic options to treat are there's a major risk that metastasis, if it is very extensive or at critical areas, it can actually lead into fractures. So we need to assess for fracture risk assessment. Overall, the disease survival is increasing with different treatments. Cancer survivors are living longer. So the importance of finding risk sites is also important in this scenario. There are various modalities to look at as we just saw. Cartography, there's the science of drawing maps. What we get from a bone scan or a whole body FDG PET-CT scan, a whole body bone scan, is just to identify where the lesions are. So that's one thing where we have molecular imaging tools, SPECT as well as PET tracers. And the other thing is to assess for the fracture risk assessment. Now, for fracture risk evaluation, this is a burning issue, a paper, a review published in 2021. Basically, this biomechanics is involved, and in this graph, you can see that there's a linear relationship initially when there's, the bones are able to bear the brunt of the remodeling going in itself. Then it becomes very strainful, and then finally it fractures and breaks. So there's an elastic domain of that bearing the stress. Then there's a plastic which can live to deformity, and you can see cortical loss, and then finally it has to break if left untreated. From this paper, two examples on the top, you got this sagittal and axial section through a myeloma lesion in the vertebral body. Myeloma, as we know, is predominantly and purely lytic, so you can see lytic lesions there at T8 and T9. In the second row, we have uterine cancer, which there's a predominant lytic lesion at the baseline, which with treatment 2 months, 4 months shows a lot of sclerosis, while there was one part of this lesion which remained lytic, and then 6 months down the line, it became that lytic component which was not responding, while the sclerosis was response to treatment. The lytic component sort of predominates and then takes over the whole lesion, and this is progression of the bone metastasis after some partial treatment response. Again, the authors have highlighted, if you see in this curve, this blue line is the higher risk of fracture. Initially, there's anti-cancer drugs, which actually puts the whole body, the entire metabolic system into a sort of challenge, and the risk of fractures increases. Then there is healing of the bone, and then eventually when the cancer is in remission, there's condensation, and there's a risk of fracture sort of decreases. And at the bottom, they've shown images that the patient has been treated with calcium, vitamin D, and the bone-targeted treatment options. The sclerotic response, as we saw in the previous lesion, in the The sclerotic response actually shows the strengthening of the bone, and then if there's some disease left, that would be coming back as a destructive thing later on. Now, there are two risk scoring systems at the moment, primarily based on radiology. This blue box shows you the Maris scoring system for the long bones, and this green box shows you the spinal instability neoplastic score for the spine. There are various factors to it. Basically, they depend on the site of the lesion, the nature of the lesion, lytic or mixed or plastic, pain caused by that lesion, extent of the lesion, how much of the bone is involved. Alignment and collapse are more to do with the spinal scoring system. Eventually, the Maris scoring system, essentially for the long bones, categorizes into low fracture risk, borderline, or the impending fracture. Similarly, on the spinal system, there's stability, potentially unstable, and the unstable. So you can see, there has been effort to come up with a risk assessment for fracture. This is a paper from Hamza Mutsa, which looked at the various studies which have evaluated the spinal instability neoplastic score, and they concluded that although the relatively high reproducibility of the SNS among multiple medical species is encouraging, additional studies are needed to determine the validity of the SNS with prospective studies. So the systems, what is available to clinicians and the imaging people is there, but it has its limitations. Metastasis happen, bone metastasis happen in all malignancies, so there's variation in the presentation and the lesion characterization. They have tried to come up with systems of score which can be applied to most, if not all. Now, in this paper, nice review article, Fracture Risk of Long Bone Metastasis, a review of the current and the new decision-making tools for prophylactic surgery. Humayun and the team have looked at that there's a multifactorial problem, as we saw from the initial slides. A multidisciplinary approach is required. We have to come up with a system easy to input, limited in number and complexity, and cost-effective to score the risk of fracture in a bone metastasis. There are radiological features or imaging features, and of course, machine learning is or can become a crucial part of it. They actually compared the three available systems. One is the Maris scoring system, as I discussed in the long bones, in which a score higher than 9 has got high sensitivity, but there is limited specificity with that. Then there is a axial scoring system on the CT, which 30 millimeter of cortical bone involvement, and then there is another scoring system in which the extent of the cortical involvement is used, which has got very high specificity. But these ACI and CCI are based on CT, and the Maris scoring system is based on X-rays. They further added to this evaluation FDG PET-CT. Here you can see at number 3, in which there are studies. We have looked at the proximal fracture, femur fractures, and they found that the glycolytic volume could be a good predictor with high specificity, relatively high specificity as compared to other scoring systems. In this table, you can see at top there's a Maris scoring system, and then we have the CT rigidity assessment and CT finite element assessment. These are computational programs based on CT trying to evaluate the risk. This is a good pictorial. I couldn't get the images for these, but basically this also highlights that the Maris scoring system based on X-rays has good sensitivity but poor specificity, while the CT rigidity and finite assessment with the computational programs have better reported specificity, but then they require specific training and computational tools to actually evaluate it. The simplest and the most commonly used Maris score has a tendency to overpredict the fracture risk. So now, as we look forward, we just see the need for assessment for prophylactic fracture femur stabilization. The idea is that if we are able to effectively calculate the risk of fracture, we can intervene early, and that has got a better outcome as compared to fractures which actually happen, because then it has an impact on the quality of life and the outcome as well. The fracture assessment clinical decision making for patients with metastatic disease, multiple papers established that there's survival advantage to prophylactic stabilization as compared to when pathological fractures actually happen and then they are taken care by the orthopods. Radiotherapy is used for metastatic bone disease. Again, in a bone at risk of fracture, radiation therapy used earlier has better outcome as compared to radiotherapy for pathological fracture once they have happened. Radiation therapy also reduces the pain caused by the bone metastasis in addition to avoiding the pathological fracture. In this paper, they have compared the outcomes of intermediate nailing between impending and completed fracture. They normalized most of the factors, and then they realized the conclusion was that patients with metastatic femoral tumors who underwent intermediate nailing in the impending fracture group had better post-operative survival, gait function, less blood loss, and shorter durations of surgery in hospital. So it's clearly that it's best to actually identify impending fractures and fix them early on. Here it needs to be highlighted that if with this risk, if they start over-treating fractures which are not at risk, that's also not a good idea because the cancer patients have a higher risk of having post-op complications. So you don't want to treat bones or metastases which are essentially stable. So it's important to differentiate between the two. This is a pathological fracture healthcare resource utilization assessment across 8 European countries. And they say that, one skeletal event or multiple events, again, it has an impact on the cost, the increased number and duration of inpatient stays for the pathological fracture of the long bones was more than fractures or problems with metastasis in other bones. So again, the weight-bearing areas, particularly the femur, which has got an impact on the quality of life more than other lesions, is important, and then it of course translates into healthcare resource utilization and costs. Now, with this background, going back to this paper from Nguyen in which they looked at the Mile score of 9 is with high sensitivity but poor specificity, what can we do? It's the time to think about SPECT-CT. Bone scintigraphy has changed with this SPECT-CT tool that we have in our hand. So based on this, we looked into literature. This is a pilot study which was done at Chicago Thana Hospital in which we used the SPECT-CT bone scintigraphy to come up with a modified Mile score, and at the bottom you can see the two tables. Table 1 is about the conventional Mile scoring using the X-ray. Modified scores, we were able to add in this characterization of the lesion where it was plastic mixed or lytic on X-ray, we could evaluate it better as plastic or predominantly avid lesion, mixed or predominantly lytic based on the SPECT-CT. Additionally, we could look at the size XL-CT better than what we could see on a 2D X-ray, and we could also see other factors. And so this is the differentiating, the modification in the Mile scoring system. So in this pilot, we saw that in the patients who are having a Mile score of 8 on X-ray, it became sort of only 5 patients were left with score less than 7 on SPECT-CT, while in patients greater than 9 at high risk of fracture, SPECT-CT was able to identify more patients as compared to the X-ray. The area in the middle, the score, patients with score of 8 are the ones which are the tricky ones. So the score with 9, greater than 8 actually go for prophylactic fixation. The score with 7 can be observed conservatively, while the 8. So basically SPECT-CT help shift the patients from the high risk into low risk. Here are a few examples here. The score 7 becoming 8. The images, I'm not sure whether reflecting that well, but in this image you can see that the lesion was predominantly lytic. From 9 it remains 9, and from this one 9 becomes 11. There's more lytic components. So essentially cortical lysis was noted in 8 by SPECT-CT versus 2 by the X-ray. Additionally, SPECT-CT parameters were circumferential involvement could be better evaluated, and X-osseous component could also be seen in 3% of the cases.
Dr. Humayun, we are running short of time, so if you can
Ji.
just hurry up, please.
Yeah, I'll just a couple of slides now. I'll be quick. So this is a paper about the role of FDG PET-CT in assessment of femoral pathological risk. And in this study, you'll know that look at the glycolytic component of a metastatic lesion in the femurs. And they basically said the quantitative measures of FDG avidity may help identify breast cancer patients. They came with a TLG cutoff of 81, which has got accuracy, sensitivity, and specificity around 83% to 80%. So basically, going back to the new tools of decision making about prophylactic surgery, I've shown you two papers, one with this from bone spec CT, modified mild scoring, and the other from the use of FDG PET-CT. So these are the new tools. Now you can see that this paper on spec CT was published in 2018. The FDG paper was published in 2017. This review was published in 2021. Now since this, like almost 5 years ago, these papers on spec CT and PET-CT have been quoted in various review by the orthopedic teams that these are the new upcoming tools, but there haven't been many studies around these new ideas and new options. So some more data needs to be required, is required to actually verify these techniques for the utility. So in conclusion, we know that the global incidence rate of cancer is projected to increase. Newer therapies, there's better survival, which requires better prolonged, better quality of life. Prophylactic treatment of possible fracture risk, long bone weight-bearing fractures is important factor in quality of life, and we need some risk assessment tools. They are available in conventional nuclear medicine as well as PET-CT, but more needs to be done. The nuclear medicine can offer these tools, cartography, of course, mapping we can do with the whole body scan and FDG, but we need to get some more tools. CT is there with hybrid imaging. We have the CT at our disposal to offer that sort of risk assessment. Thank you very much. I would like to conclude my talk. This is a picture from the recent ENM board exam faculty meeting in Hamburg. And I've put here this midwinter meeting coming up with a November 6th abstract deadline. There are special incentives for research done in Pakistan to be presented at this meeting. And obviously, PSNM offers membership, free membership to residents, and more people from Pakistan should actually avail it. Thank you very much.